1 year, more than a year, we are conducting this PGCME very well, and it is very well appreciated not only in Kerala but also in all states. I think the participants from all states are attended. Today, IAP Kozhikode, very happy that IAP Kozhikode hosting this, and the presenters from Kozhikode. Hello? Hey, audible?
Yes, audible.
Okay. So I request Dr. Rajesh, the mentor of today's program, to introduce the faculty and the presenter and the case.
Good evening, all. I think it's clear. Audio?
Yes.
Okay.
Yes, clear.
Good evening, all. Respected senior teachers and colleagues and residents of pediatrics. First of all, thanking for this opportunity. And today we are going to discuss one case with some deviation from the normal genitalia. So to discuss that, we have none other than our Vijay Kumar sir, who is an experienced and very good teacher and a pediatric endocrinologist known all over the India. So sir is going to discuss the case, and the case is being presented by Dr. Anashwara, our final year resident. Sir will discuss the case in between. Over to Anashwara for the presentation. Sir.
Hello.
Sir can start, sir.
Can you hear me?
Yes, sir. Yes, sir.
So, good evening to all. First of all, thank you so much for IAP Calicut, Dr. Mohandas, the PG coordinator, Dr. Aslam, Dr. Sindhu, president of IAP Calicut, and Dr. Jishin, secretary, and Dr. Rajesh, mentor. And thank you for the nice introduction. And the case presenting here is a child with atypical genitalia. That is usually a perplexing situation that is faced by all pediatricians. And even though many can be managed without much problem, so that will create an undue anxiety in the parents. So whether the sex is male or female, that is an important question that a parent wants to get a very immediate answer. But unfortunately, we cannot give such answer in the newborn period or even years after his or her birth. So today, Dr. Anashwara is presenting a case of ambiguity or atypical genitalia that is detected little later in the child's life. So I think over to Dr. Anashwara for the presentation. All other PG students and other residents from here or outside can put their queries in the chat box. In between, I'll ask questions. The answer also you can put it in the chat box. We can discuss it later. Over to Anashwara.
Good evening, everyone. Presenting the case of Aradhya, a 10-year-old girl hailing from Kannur. The informant here is her mother and the history is reliable. She presented with chief complaints of enlargement of clitoris for the past 6 months. Coming to history of present illness, apparently normal child till 10 years of age presented with complaints of enlargement of clitoris noted by the child herself 6 months back. This was insidious in onset and gradually progressed over a period of 1 month. There is no history of pain over the swelling. There is no redness or any skin changes. There is no history of local trauma, no history of fever or any discharge from the genital area. For this complaint, the child was taken to a local hospital from where child was advised referral to a higher center for detailed evaluation. Child had development of pubic hair at 9 years of age. There is no axillary hair or breast development noted. No history of any inguinal swellings. No history of sudden increase in height noted. no history of voice changes or acne, no history of hirsutism, no history of any abdominal distension or mass, no history of any drug intake present or past. Child has not attained menarche till now.
So, Anashwara, I'll have some questions. So, what is the child in puberty?
There has been no history suggestive of any pubertal growth spurt or any pubertal changes except pubarchy. Child has attained pubarchy at the age of 9 years.
The child has attained, what about his breast development?
According to history, child has not attained breast development. There is no development of breast.
So here the pubarchy started first and child has not attained breast development. So is there anything you have to tell?
Usually, in this case, there is an abnormality in the order of attainment of puberty. Usually, puberty won't be attained first. Usually, in a girl child, during the progression of puberty, thelarchy attains first. That is, breast development occurs first before the attainment of puberty. Here, there is an abnormality in the order of attainment of puberty.
Usually, the thelarchy is under the control of hypothalamic, pituitary, and gonadal axis, and the pubic hair development is under the control of adrenal gland. Usually, this is the thing. Usually, thelarchy comes first and pubarchy comes later. Sometimes there will be isolated pubarchy also. Second thing, what is the importance of sudden increase in the height?
This is to ask about the pubertal growth spurt. That.
So what is the difference between the pubertal growth spurt in boys and girls? So pubertal growth spurt in the girl starts a little bit early in the tanner stage 2 and 3. So along with thelarchy, usually they will be having, or along with the pubertal development, they will be having increase in the height velocity. But in boys, it occurs a little bit later during tanner stage 3 or 4. So initially there will be testicular volume enlargement. Then gradually the height increment will be noticed. In girls, height increment will be there along with the onset of thelarchy usually. So it has not occurred actually. Then what is the importance of voice changes, acne, hirsutism?
This is to ask about, because the child has already had pubarchy. This is to ask about the action of any androgens in the child, any androgenic actions.
Effect of androgens.
Effect of androgens.
So inguinal swelling?
This is to ask about any palpable testis that has been there or not, in case if there is any abnormality.
Abdominal mass?
Abdominal mass, like here, we're talking about androgenic action. So
clitoromegaly.
Clitoromegaly. So we have to rule out if there is any abdominal tumors and androgen secreting ovarian tumors or any adrenal tumors that is causing this androgenic action.
Okay. Drug intake?
Drug intake to rule out any external androgens that has been like some drugs like spironolactone, danazole, etc. can cause exogenous androgen exposure. So this can also lead to clitoromegaly.
So some creams or something which is having some androgen action or something like that. Okay, very good. Then go ahead. So this is a child who developed clitoromegaly, and along with that there is a pubic hair development, but he has not attained thelarchy. Okay.
Coming to the treatment history, due to the above mentioned complaint, the child was taken to a local hospital from where she was referred to a higher center for further management. From where blood investigations, ultrasound and MRI was done, and the parents were told that the child requires an abdominal surgery. Then the child was referred to our center for surgery. A laparoscopic surgery was performed after 1 month, after which the parents noticed some decrease in the size of the clitoris. Child was started on oral medications then to be taken daily and was advised monthly follow-up. This is the treatment history. Coming to the past history, there is no history of any chronic drug intake, no history of any surgeries in the past, no history of prior hospital admissions. Coming to antenatal history, first trimester, She's the second child born out of non-consanguineous marriage, conceived spontaneously, confirmed the pregnancy at second month by urine pregnancy test.
What is the one question? What is the importance of consanguinity in this child?
Many disorders like CH, which can cause virilization, can be autosomal recessive inheritance. So if there is any consanguinity, there is chances that if two carriers are there in the family, child can be affected.
So any other thing like CH, of course, CH is the commonest cause of genital ambiguity in any child. So autosomal recessive inheritance is there. Any other inheritance pattern in some cases of
androgen insensitivity syndrome, it can be X-linked recessive inheritance. And many other syndromic associations are also there. Yes. Along with ambiguity.
So what will be the X-linked recessive means? What will be the classical picture of androgen sensitivity? That will be females will be
carriers and males will be affected.
But you won't get that history in a case of androgen insensitivity, because all these males, so-called males, will be living in our community as females, because androgen insensitivity, the presentation may be female. So don't get confused, but always the X-linked recessive inheritance is very common, androgen insensitivity syndrome. Okay.
So she has been conceived spontaneously, confirmed pregnancy at second month by urine pregnancy test. There is no history of any drug intake in the mother other than supplements.
So any drug intake in the mother can develop atypical genitalia in the child?
Any androgenic drug intake like danazol, any other drugs like spironolactone, minoxidil, also anti-epileptics like phenytoin can also can lead to virilization in the fetus.
The phenytoin and phenobarbital and phenytoin are called as endocrine disruptors. That can produce a lot of abnormalities in the genitalia in the child.
Coming to second and third trimester, quickening was felt at 5th month of gestation. Mother pursued fetal movements normally throughout pregnancy. All antenatal scans done was normal. No history of gestational diabetes, hypertension, or any other comorbidities during pregnancy. No history of bleeding or leaking per vagina. There is no history of any hyperpigmentation or virilization in the mother during the course of pregnancy.
What is the importance of hyperpigmentation and virilization in the mother?
In case of maternal androgen excess, the mother can also have virilization. Also in CAH, the mother can have virilization during pregnancy. In such cases, the baby born will have virilization, like female born will have virilization and atypical genitalia.
Some condition, even though it is very rare, aromatase deficiency in the mother, or maternal tumors, ovarian tumors or something like that, that can also produce some amount of virilization in the baby. Okay.
Coming to natal history, she was a term baby delivered by a normal vaginal delivery, had a birth weight of 2.5 kg and cried immediately after birth. Postnatal history, there is no history of NICU admission, no history of hypoglycemia or seizures during the postnatal period, no history of poor feeding, incessant cry, or poor activity during the neonatal period, no history of any abnormalities in the genitalia noted at birth. There is no history of hyperpigmentation of skin during the postnatal period, and the baby was feeding well during this time and was discharged after 3 days.
Okay. So, suppose a baby is having atypical genitalia, what is the immediate risk that will get in the newborn period?
If it is due to CH, the child can have adrenal salt wasting, and the child can have hyponatremia, hyperkalemia, and complications due to salt wasting, can have adrenal crisis.
Okay. Also, whatever may be the atypical genitalia you notice in the newborn period, the importance should be given for stabilization of the child and ruling out congenital adrenal hyperplasia. All the other things we can wait for some time. CH should be ruled in any case of ambiguity by investigating sodium potassium. So what will be the fallacy of investigating in the early newborn period?
Usually it will be normal in the early days. Vaginal crisis only occurs after around 2 weeks of age.
So even though you get a normal sodium and potassium in the first few days of the life, you have to continue investigating for that, because adrenal crisis can happen in the second week or third week in a case of CAH. And another thing is 17-hydroxyprogesterone level will be abnormally high in the immediate newborn period. So it will come down after 48 hours. So that is the essence of newborn screening we are doing after 48 hours. So we have to repeat it if you have done it the early newborn period. So anyway, diagnosis of congenital adrenal hyperplasia is the most important thing in the newborn period. Then
Development history. She has attained all milestones appropriate for age. Is now studying.
Clear or not? Okay. Okay. Continue.
Anasara, voice is not clear.
Clear.
കേൾക്കാമോ സർ? Hello, sir.
Okay.
She has attained all milestones appropriate for age. She is studying in 5th standard and has a good scholastic performance.
Okay.
Diet history. She has been exclusively breastfed till 6 months of age. Complementary feeds were started after 6 months and breastfeeding was continued till 1.5 years of age. Child is now receiving adequate calorie and protein for age. Iron-rich food, green leafy vegetables and fruits has been included in diet. Coming to immunization.
Okay, continue.
Child is immunized up to age. Last vaccine was taken at 10 years of age. There is no adverse event following immunization.
Okay, good.
Coming to the family history. The mother has attained menarche at the age of 13, has regular cycles now. There is no history of similar complaints in the family. There is no history of infertility. There is history of infertility in paternal great aunt. There is no history of any amenorrhea or pubertal delay in the family. There is no history of corrective genital surgeries. There is no history of any abdominal surgeries in any family members. There is no history of neonatal death due to dehydration or any unexplained IUDs.
Good. Continue. So, okay.
This is the pedigree chart. She's the second child and also had one abortion before. This is the paternal great aunt who is having infertility.
But I don't think there is not much importance to that.
Socioeconomic history. Father is studied till 10th standard and is now a daily wage laborer. Mother studied till 12th standard and is a homemaker.
Finish your food fast.
Ration card is APL and they have enrolled in insurance. To summarize the history, a 10-year-old girl, developmentally normal, immunized till age, apparently normal till now, presented with complaints of enlargement of clitoris noted by herself 6 months back. There is no pubertal changes in the breast or axilla. There is no history suggestive of salt wasting and a family history of infertility in maternal great aunt.
Okay, before telling the differential diagnosis based on the history, I think Dr. Rajesh can ask some questions or add something. Any clarification? Rajesh?
Sir, I want to ask this question. Like sir said, whether this is this infertility in paternal aunt. This is it was in paternal aunt, no?
Paternal aunt.
Is that relevant?
Actually, it's great aunt. Usually, like in androgen insensitivity syndrome, there can be relatives with if it's X-linked recessive, there can be relatives with infertility.
So, who will be affected? Maternal aunt or paternal aunt? It is X-linked, no?
X-linked.
So, maternal, uncles. I mean, it actually the uncles, they will be actually males, but living as aunts, females. They will
I
be
think
infertile.
yes, as Rajesh said, if it is a maternal aunt, it will be better. Like, it will be.
But previous slide, it was paternal. Actually, it is paternal aunt, right?
Paternal.
Okay.
Did you understand that? Suppose it's a maternal aunt. That aunt will be a male actually, but he will be living as a female. So that will be more important. Anybody,
sir.
Dr. Hiba? Any PGs? Akshaya? Akshaya is there? Or Hiba?
Sir,
Any other questions or any other clarification required? Okay. If nothing is there, Rajesh, can we?
Yes, sir. We can proceed with presentation.
So, with this history, what are your differential diagnoses, Anusara?
Here, according to the history, the child has features of virilization, clitoromegaly, and that has occurred at the age of 10 years. So, the first diagnosis we suspect is an antigen exposure. That one is late onset CAH, and that would be my first DD. And another differential diagnosis would be an androgen secreting tumor either in the adrenal glands or the ovaries. Or it can also be due to any external androgen exposure, exogenous androgen exposure due to drug intake, either oral drug or any topical application of drug over the genitals.
Okay, I think these three are the most important questions. Anybody is having a other differential diagnosis, you can put it in the chat box. Okay, but suppose why the CAH, the late onset CAH, is your first diagnosis, first differential diagnosis? Since that is very common.
CAH is the most common cause of any atypical genitalia. Also, less severe forms of CAH can present later in life without much features of salt wasting and virilization, as in only with virilization.
But there is no growth acceleration in this child. Still, you can get. So, androgen secreting tumors, ovarian tumors, and all.
This onset is at 10 years of age. Any androgen secreting tumors in the ovary or adrenal can cause virilization, and the child has been normal, has been having normal genitalia till 10 years of age.
Okay, sir. Sir, one question. Like Anusara, you told that surgery was done for this child, and after that it is regressing. So, what all in conclusion you can make from that part?
If that was an androgen secreting tumor, the surgery was done for that tumor, the androgen release can be controlled, and it is more in favor of an androgen secreting tumor according to the history.
From the history, if it was CAH, nobody would be doing a surgery for that. Like they will be starting on some drugs, so that in that way that will come below the
list.
So androgen tumor would be the first diagnosis.
Okay, very good.
Okay, sir.
Importance of that surgery should give, but importance should be given to the surgery. Okay, very good.
Okay, sir.
So you can. Sir.
ഞാൻ എന്താ വെച്ചാൽ ഒരു മ്യൂട്ട് ചെയ്തു എന്റെ വോയിസ് ആയിരിക്കും പ്രശ്നം ഇപ്പൊ ഞാൻ മൊബൈലിൽ അപ്പൊ ഐ ഹാഡ് എ ഫ്യൂ പോയിന്റ്സ് അറ്റ് ദി എൻഡ് ഓഫ് ദി ഹിസ്റ്ററി ഒരു ഇൻ ദിസ് കേസ് വി ആർ ഡീലിംഗ് വിത്ത് എ കേസ് ഓഫ് ഒരു abnormal genital or virilization situation. Any of these situations, usually it seems to be a peripheral situation. Central is less likely. Still, in any situation, we need to tell about the central complaints also, like a visual field problems, headache, raised ICT features. Even though this case seems to be more of peripheral, in this, when you evaluate this thing, always include that visual field defect and headache, other central problems. Then regarding the peripheral, it can be adrenal, ovarian. There is a possibility of hypertension. Many reasons. It can be a late manifestation or subtle CAH-like presentation, or the adrenal, whatever be, there can be a hypertension. Those symptoms in the hypertension, and some of the autonomic phenomena also in the history. So that should be included in the history. And then one more thing, I think the neonatal screening started in Kerala, Shalabam program 2012, I think.
Yes, sir.
Whether at that time CH was included?
Yes, sir. It was included from the beginning.
Okay. That just keep that in mind, whether that was done in any case when you're talking about the genital problems and endocrinological, that is to be kept in mind. So in the family history, of course, neurofibroma, that set of situation, anybody else having neurocutaneous syndrome, because we had seen patient in a neurofibroma situation presenting with isolated clitoromegaly.
Yes.
Okay.
Yes.
That's all.
So newborn screening also, sometimes even in newborn screening, the classical, apart from classical CH, milder forms, the late onset will not be screened also. That is again a problem. Okay, nice idea, sir. Sir, continue. Shall we continue, sir? Okay.
General examination. Child is alert, active. Vitals, pulse rate was 96 per minute, regular rhythm, normal volume and character. All peripheral pulses were felt equally. There was no radial or radiofemoral delay. BP was 96/70 and it's at 50th center.
So what is the importance of BP?
Right?
What is the importance? Purishottam sir was already asking about hypertension and its clinical pictures. So if the child is having hypertension, what are the inferences you can make out?
One is like in adrenal tumors, we can have they can present with hypertension. Also in some forms of CH like 11 beta hydroxylase deficiency or 17 alpha hydroxylase deficiency, there can be mineralocorticoid excess which can lead to hypertension.
Okay, good.
Respiratory rate is 18 per minute with normal work of breathing. Saturation maintained in room air. CFT capillary refilling time was less than 3 seconds. There was no pallor, egress, cyanosis, clumping, lymphadenopathy, or edema.
Okay.
Coming to the head-to-toe examination, head size and shape is normal. There was no obvious facial dysmorphism, no acne hirsutism, no obvious skeletal anomalies. There's no axillary hair. Genitus, clitoris appears enlarged in size. Genital examination is done in detail later. There is no evidence of any dehydration, no cafe macules, sexual maturity staging, breast stage 1 and pubic hair stage 3.
So what is the importance? So is there any, just can you go back? Any history of, so what is the importance of the facial dysmorphism?
We have to rule out in syndromic causes also, like ambiguous genitalia, it is associated with many syndromic causes, like one is cytochrome P450 reductase deficiency. In that, we can get craniofacial anomalies. Also, many syndromes like Smith-Lemley optic syndrome and other syndromic associations has been found to be associated with ambiguous genitalia in females. So we have to rule out that.
So ambiguous genitalia may be an isolated one or maybe a part of a syndrome. So many syndromes will be having ambiguous genitalia as an association. Okay, good.
SMR staging.
So there is no history of the Scaphaeus spot. Actually, sir was discussing about neurofibromatosis. Any other condition that will produce Scaphaeus spots and some endocrine problems at least?
McCune-Albright syndrome can have precocious puberty and Scaphaeus macules.
Okay.
This is the SMR staging. She has stage 1 breast and third stage 3 pubic hair. Coming to the
so just go to the SMR staging. So one comment, Actually, what advice to the postgraduate students is, don't write SMR 1, 2, 3, 4 like that, because there will be deviation in each. So breast development, which stage, pubic hair development, which stage, that has to be recorded. Even in a male. So there will be some discordance between the breast development and pubic hair development. So we can even come to a diagnosis like that. Suppose child is having premature pubarchy. So pubic hair will develop initially, then comes the breast development. So that will happen, that variation will be there. So tell breast development stage 1. Stage 1 means that is pre-pubertal. And pubic hair development is little bit advanced. That is stage 3. So that is the importance of SMR stage. Continue.
Anthropometry. Her weight is 28 kg, which lies between 25th and 50th centile. Height is 132 centimeter between 10th to 25th centile. BMI is 16, normal. Her mid-parental height is 155 centimeter at 25th centile.
So what is the any growth chart? Okay.
Growth chart, like growth velocity monitoring, we could not get because the child has come to us only recently. So we couldn't get the pubertal growth spurt or any growth.
So again, one appeal to our postgraduate student, take the, at least if you see any child, take the height of the child. Suppose the previous height documents will be very vital in a child's diagnosis sometimes. Here, we don't know what was their height percentiles in the previous years. Okay.
Coming to genital examination, bilateral gonads were not palpable in the labioscrotal folds or in the inguinal region. Clitorophalic length of 3 centimeter and a width of 1 centimeter noted. 2 separate urogenital openings, urethra and vagina. C. Urethral meatus is located at the base of the clitorophallus. There is no pigmentation or rugae. Anogenital ratio is 0.5. And pubic hair is
Anuswara, one point. In the growth measurement in the height, child is a strong point. There is no advance in the height. But there is one more point. Mid-parental height is on the higher side. Child is having a lower height compared to the mid-parental also. So in a case like this, when you are getting a definitely on the lower centile compared to the parent, definitely what we need in this context is possibility of a hypothyroidism. So
And others mute. Okay, sir.
in that context, in the history, we need to mention few points because is there a constipation? Is there a recent deterioration in the school performance like that? Because hypothyroidism rarely can be one of the reasons for the precocious puberty.
Yes, sir. So usually hyperthyroidism produce delayed puberty, but there hyperthyroidism can produce precocious puberty also. So can you just tell me, suppose as Sir was telling, that is a very important point. In a case of hypothyroidism, what will happen? What will be the SMR staging like usually?
Usually, delayed puberty is SMR stage.
If it comes as an advanced puberty, so hypothyroidism can also produce precocious puberty. So in that case, pubic hair development will be very late actually. Sometimes even the child will attain menarche even without any pubarchy. So, but here the height is, as Sir was telling, height is very less. So we have to think of, at least we have to ask the history of congenital. Well said, sir. So here, you have to look for gonads in the labioscrotal force. So suppose some gonads are palpable in the labioscrotal swellings area and all. What is inference we get?
If gonads are palpable below the inguinal ligament, that is most likely testis. Also, it shows that there is some testosterone production also.
Yes. So whenever you are seeing a testis in the labioscrotal or inguinal region palpable, that indicates that the testosterone level, they have secreted some amount of testosterone, because testosterone is the one thing that will produce a descent of the testis from abdomen to the inguinal region at least. So and if the child is having a complete female genitalia and testosterone is the testis is palpable in the inguinal region, it may be having, child may be having androgen insensitivity syndrome, 5-alpha reductase deficiency, because testosterone is there, because testis has at least partially descended, and there is good volume is there because you can palpate it. Good. 2 separate urogenital opening is there. Okay. So no pigmentation. So here the patients may not complain about pigmentation. You have to look for pigmentation because again you have to roll out CAH. And where is the urethral meatus? There is no hypospadia. It is
located at the base of the clitorophalanx.
And you can ask the mother whether how the child is urinating. What is the importance of anogenital ratio in this child? What is anogenital ratio? And for PGs, what is anogenital ratio and what is the importance?
Anogenital ratio, which is usually measured by dividing the distance between the anal opening and the posterior faucet by the distance between the anal opening and the base of the clitorophalanx. So, if the anogenital ratio is more than 0.5, it indicates that labioscrotal fusion has occurred.
Okay. So, that indicates that some amount of virilization is taking place in that girl child. So, in CAH or all these things, you will get anogenital ratio. And depends upon the severity, the anogenital ratio increases actually. Okay. And you can just go to second. Sir, we didn't take the photo, we didn't post the photograph of the child genitalia because that is, I don't know whether it will create problems. I think we can go to the Prader staging and she will explain.
Here, the anogenital ratio is 0.5. So, it indicates that the labioscrotal, there is no posterior labioscrotal fusion. So, here the Prader stage is 1. That means only clitoromegaly without any labioscrotal fusion.
Okay.
Now coming to systemic examination. Abdomen inspection, there is no visible distension or mass. There are 3 linear laparoscopic scars of size 2 cm each, noted just below the umbilicus and on the either sides of the abdomen in the iliac region. No scar hypertrophy or keloid noted. A linear varicose lesion of size 5 cm in length is seen over the medial aspect of the left thigh. Umbilicus is normal. There is no dilated veins, scars, or sinuses. Palpation reveals no mass or organomegaly. Percussion is normal.
What is that verrucous lesion? Child was on some medications, some estrogen cream.
Child is not consulted for the verrucous lesions.
Even the creams can produce androgenization. Continue.
Other systems, cardiovascular, respiratory, CNS, and skeletal systems were normal.
Actually, as Sir was discussing, CNS also you can tell about the fundus, field defects, and all these things. Skeletal system is also normal. No other murmurs or no other systems are not affected.
Not affected. Coming to summarize the history and examination. A 10-year-old girl, developmentally normal, immunized till age, apparently normal, presented with complaints of enlargement of clitoris noted by herself 6 months back. It's no pubertal changes in the breast or axilla. Family history of infertility in paternal aunt present. Examination showed clitoromegaly with Prader 1 with stage 3 pubic hair development, not attained menarche. Provisional diagnosis includes androgen secreting adrenal or ovarian tumor, late onset CAH, and exogenous androgen exposure.
Any other differential diagnosis in the chat box? No, not. Any response in the chat box? Nothing. Anybody?
In that pedigree, he has shaded 2 members in the family. Other.
No pedigree. Go to the pedigree.
One is the paternal aunt and the other this child. So when we shade similarly, that implies that both are having same problem.
Yes.
I think we cannot shade
that color we can delete. Yes. And you can write something there.
Yes.
That may be better. Okay. Very good point.
One point. We were discussing the relevance of the capillary spots, and you already told one possibility, rare possibility of a neurofibroma. Second, McCone-Albright syndrome. There is a relevance of the head circumference measurement. Vijay, will you get that the skeletal problem with the head circumference change also will be there in McCone-Albright?
Yes, yes.
Sorry, sir.
A head circumference measurement should be there.
Yes, I've measured the head circumference.
It is there.
It is there, sir. It is there. 54.
Only thing, just to think about that. That's another way of relevance is that you may not be considering that point. That's all.
Yes, sir. Yes, sir.
Sir, one more point. Short. When sir was telling about the short stature, if it's not marked short stature, but being a girl, one should consider the possibility of Turner syndrome also, isn't it, sir?
Yes, yes, yes. Definitely.
And CVS should look for the heart disease, if any.
Good
So
point.
you can get platelet.
A Turner syndrome can also produce ambiguity in genitals sometimes. Good point. Another thing is, you won't get, in a Turner syndrome, you won't get all the dysmorphic features also. Sometimes Turner will come to you with just with short stature and delayed puberty. That is well described. Very good. Continue.
Coming to the investigations part.
So what are the investigations that we are planning? We have not done any investigations so far because this child is coming late. So what investigation we will plan?
First, we have to do baseline investigations. Since we have considered one possibility as late onset CAH, we have to do serum electrolytes. Sodium and potassium values should be checked. Hypothyroidism should also be ruled out. So TSH and FT4 should be done. Then 17-hydroxyprogesterone values should also be done. And after these investigations, we can do imaging, like ultrasound abdomen to look for the internal genitalia.
Karyotyping?
Yeah. After imaging, we have to also do karyotype. Then the hormonal levels.
Okay.
One point, Anishura. When we start and tell about investigation, simplest investigation, non-invasive investigation, cheapest investigations. In a case like this, before you go for the invasive things, one most important thing is the bone age. So
I was about to ask about bone age.
Then only go to the invasive and costlier one.
So bone age is, I think I was just about to ask that question. And thank you, sir, for pointing out, because bone age is very important. So these are the very basic investigation. So if you have done it, so we can start with that, all this investigation, bone age and all these things.
So her routine investigations, serum electrolytes were done. Sodium was 138, potassium was 4, it was normal. 17-hydroxyprogesterone levels were also normal. Serum cortisol levels were done. 8 AM cortisol was found to be less than 1 microgram per deciliter.
We have repeated it?
We have planned repeating and we have advised the parents to come back to the investigations.
Thyroid function test?
Thyroid function is also normal.
Bone age? Normal.
Bone age, normal.
So these are the investigations, sir.
Ultrasound abdomen. Ultrasound abdomen done showed bilateral adrenals normal, no adrenal mass noted. Uterus was pre-pubertal status. There was oval, homogeneously a hypoechoic structure in the left adnexa, measuring 14.5 into 9.9 mm. There was no follicles noted. The right gonad could not be localized. This was the ultrasound finding.
Any other so what is your inference regarding that ultrasound finding? There is uterus is there. What is that oval homogeneously hypoechoic structure in the left adnexa?
This can be an ovary, but in the ultrasound, there are no follicles noted, so we cannot be sure if it is just a mass or a female gonad.
Right side ovaries are not visualized. Okay.
Due to the inconclusivity in ultrasound abdomen, an MRI was done in this child. MRI abdomen again showed both adrenals normal in position, but it showed horseshoe kidneys, which is noted with normal renal parenchyma and no evidence of HU. Uterus was again prepubertal in status, and but ovaries could not be visualized in MRI. USG screening was showing the oval hypoechoic structures, and the right gonad could not be localized with the MRI.
Which condition you will get usually horseshoe kidneys?
Yeah. Turner can get renal anomalies.
Okay.
Due to these findings, a hormonal assay was done, which showed raised FSH and LH levels. FSH level was 121.8 and LH levels 84.3. Estradiol levels were low, but testosterone levels, which was done, was 1.9 nanogram per ml. DHCS levels were not available in this study. Further investigation.
Further, you can continue and then we can discuss.
Further investigations were done. Next, we have done a karyotyping, which actually showed 46XY karyotype. So these were the investigations which was done in this child. After
so how many cell lines they have done in karyotyping?
In this report, this karyotyping was done from outside. They have not mentioned whether they have counted 50 cell lines or not. They have not mentioned about the number of cell lines.
So I think if you have a karyotyping like this, at least 50 cell lines should be done. Otherwise, sometimes some mosaics we will miss also. Any further comment by Mohandas?
Always you should mention how many counted.
So if you believe this, this child's karyotyping is 46XY. And you can go back to the ultrasound examination. History and external genitalia looks like a female only. It's mild clitoromegaly. Otherwise, there is no posterior labial fusion and all that. And inside the abdominal ultrasound, uterus is present. And one homogeneously hypoechoic structure in the left side is there, but right gonad cannot be visualized. Then our differential diagnosis is completely different actually. So if you we can think that this gonadal, this karyotyping is 46XY, then what are the possibilities this child is having? An XY DSD, XY child with a uterus and some abnormal structures. We don't know. Now we don't know whether previously we thought that it may be ovary. There is a structure is there. We don't know what ovary or something like that. But uterus is, in all the ultrasound and MRI, uterus is there. So how can we modify this, your differential diagnosis now?
Here now, this is an XY DSD, but in an XY karyotype, we have all Mullerian structures preserved. So in an XY karyotype, to have a preserved Mullerian structures, there should not be any AMH. So there should be one possibility here is pure gonadal dysgenesis. That is, dysgenesis has occurred early in the
very early in the fetal life.
XYR syndrome. There can be persistent Mullerian structures with XY karyotype.
Because here, if it is this, if we can believe this karyotype, so this is an XY DSD with a uterus, intact uterus is there. So this is a defect of testicular development itself. So very early in the period, so testicular development is damaged. So there is no testosterone. There is no AMH. So there is uterus is there, because Mullerian structure is there, because there is no AMH. That we have to do like that, because there are XY female will be there sometimes. So this may be that type of disease. So many will be associated with some chromosomal anomalies, SOX1, WT1, all these things will be there. So they will be having some renal anomalies, all these things we have to look for. That is one thing. Any other possibility? In which Mullerian structure is there?
Mosaicism can also be there, like XY karyotyping.
So another baby, persistent Mullerian duct syndrome, in which AMH is very low. So that will produce Mullerian structure, but they will be having Wolffian structures also there. And usually the external genotype will be like just like male. So other XYDSDs like testosterone biosynthetic defects, like all these things will be having associated CAH, and there won't be any Mullerian structures because AMH is there. So Mullerian structures won't get developed. So internally it will be a male only. And things like defect in androgen action, like 5-alpha reductase deficiency and androgen sensitivity syndrome. Internally, there won't be any uterus. Externally, they will even complete androgen insensitivity syndrome. Looks like a girl, but uterus may not be there. Here, one thing is uterus is there. So that may be the reason. And another thing, Mohandas, whether we have to repeat karyotyping. And because it may be a mosaic, another possibility I am having is maybe a mosaic like 45X, 45, 46XX, because there is horseshoe kidneys there. Oh, and is there just like a fixed gonadal distance?
Horseshoe kidney is there, short stage there.
Oh,
Bone age, what you mentioned?
Bone age is normal.
Bone age is normal.
Appropriate
Normal,
for
sir.
chronological.
Appropriate for chronological age.
Okay, so with all this, Rajesh was saying in Turner you can get clyperomegaly. So with all this, I think repeat karyotyping will be needed because in the whatever report we have, they have not mentioned how many cells.
എനിക്കും question in a karyotyping, there is a subjective element. You are identifying the Y chromosome. Sometimes if there is we are going wrong, why not other molecular tests where the Y elements are more specificity of the test? Is there any molecular? Can we go for a molecular test in a case where like this? The karyotyping is a cytogenetic test where we can go wrong. Molecular test in the advances in the
I think what we are planning is, I think we are going further with the other investigation. At this time, karyotyping. So what other investigation for molecular genetic test that we are planning actually?
Sir, one more.
So before that, we can go for the this thing, surgery finding.
Sir, before that, sir, the hormonal pattern. Before that slide, this suggests that there is, XY pattern is there. Testosterone is the hormone that is increased.
So what Adishwara, I think we can discuss about this FSH, LS, estradiol, testosterone, all these things. So what is your comment?
Here, the gonadotropins are high. FSH and LH has been produced, but the estradiol levels are low. That means ovarian activity is not there. But the testosterone levels are high instead of estrogen levels. So that means like mostly a functioning testis is there.
Testicular tissue is there.
Testicular tissue is there.
So that might have produced some amount of clitoral hypertrophy, because still the child has not attained puberty so far. In this pre-pubertal days, child is having some structure like clitoris, but now the child has entered into puberty because LH is elevated, FSH is elevated, because that indicates that the hypothalamo-pituitary axis started functioning, but estradiol is low. That production of estradiol is less, but there is some amount of testosterone has action is there. That might have produced some amount of clitoral hypertrophy in that child.
Sir, at this point, if that uterus was not there, we could make the diagnosis of IV alpha reductase.
Yes.
Isn't it?
But that history of androgenization. That is what I told, because partial androgen insensitivity, 5-alpha reductase, all these things will develop some amount of virilization in this time, at this time, because usually 5-alpha reductase, they will be just like a girl till puberty. Then suddenly even their sex reversal will be there. They will convert it to boys because of the effect of testosterone. But here the problem is uterus is there.
Uterus. Yes, sir.
So we have to go back in the very early stage.
Okay.
എനിക്ക് തോന്നുന്നു androgen production, testicular development in the stage problems.
Okay, we'll see, sir.
Due to these investigations, child was advised surgery. The surgery done here was diagnostic laparoscopy with cystogenitoscopy. So the laparoscopic findings were there was a left dysgenetic gonad of 1.5 into 1 centimeter, which had smooth glistening surface, and on the right side there was a streak gonad of 0.5 to 0.5 centimeter. Uterus was seen, tubes were normal, fimbriae seen, and cystogenitoscopy done showed normal urinary bladder with normal bilateral ureterus opening. After the diagnostic laparoscopy, bilateral gonadectomy was done and excision biopsy was sent.
Okay.
Excision biopsy report showed testicular tissue on the left side with testis showing leading cell hyperplasia, and on the right side the biopsy specimen showed fallopian tube, epididymis and ovarian tissue. This was the surgery and findings.
So left side more of a testicular structure. That swelling, that may be a testis usually, because that shows features of testicle. Laparoscopy, then biopsy report.
Yes, sir.
So leading cell hyper. Right side, there is fallopian tubules and ovarian tissues are there.
Again, possibility of Turner, we have to consider a mosaic Turner.
Yes.
When there is a Y chromosome, that can
Next.
and it can be turn minus.
It looks like just like in a mixed gonadal dysgenesis. One side there is testicular tissue and other side there is ovarian tissue. But external genitalia doesn't have any features of mixed gonadal dysgenesis. Usually one side will be prominent, other side will be like that. That is not there, just like a female external genitalia. Sir?
At the end of this thing, it seems to be very, very, very interesting. But just one point, I am going back, and with the last comment, still there is a possibility you need to consider Turner. So at the stage when you are getting an ultrasound picture of the horseshoe kidney, that's such a entity so rare. There, what you need to go back and check is the lower limb femoral pulse, radiofemoral delay, and the BP in the lower limb. You said the Turners can still be there with a normal appearance. That is always holds good here. Whenever you are getting it, like cardiovascular examinations are must.
Yes, sir.
Here, sir.
Next slide, please.
Based on these investigation findings,
Next slide, please. Okay. Before that, you can tell. Continue.
So, based on these investigations and examination, we are summarizing the case. So, this is a 10-year-old girl.
I think what further investigations and for what all things we have to do, we can discuss later. Okay, continue. Summarize. We can summarize.
Here, this is a 10-year-old girl who presented with clitoromegaly, just noted 6 months back. There is no thelarchy or axillary hair. Examination showed clitoromegaly Prader 1 with stage 3 pubic hair development and no hyperpigmentation. Routine investigations showed normal electrolytes and 17 OHP levels. Imaging done showed presence of Mullerian structures and unilateral adnexal mass with normal sized adrenals. Karyotyping done came as 46XY karyotype. Then a diagnostic laparoscopy done relieved left-sided smooth glistening gonad 1.5 into 1 centimeter and a streak gonad on the right side. Bilateral gonadal biopsy was done, which showed testicular tissue on the left side and ovarian tissue on the right side. This is the summary of the child. Based on this, the possible diagnosis we have come here is mixed gonadal dysgenesis over testicular DST.
Mixed gonadal dysgenesis, or second possibility is still it may be an XY DSD or partial gonadal dysgenesis or complete gonadal dysgenesis. So how to investigate further and how to manage. So this is so many problems are there. So whatever may be the diagnosis, main problem is the sex of rearing, whether to do gonadectomy, and what are the final complications. All these things are different. So now there are some laws are there. So whatever may be the diagnosis, how to manage the child, how to rear her, what is the sex assignment should be done. All these things are very important in any case of DST. Okay. All DST may not be as simple as CAH. Okay. So what investigation are we planning? With our Mohandas sir's help, Purushottam sir's help. Are we planning to repeat karyotype? Is it needed 50 cells karyotype? I think Shankar also is there in the this thing. Both of Mohandas and Shankar can tell. Second is genetic test. So these two. Mohandas.
Can you, simple words, you can explain how a male or female this development of this, you get a better idea.
Genital development. So, the internal genital development it usually begins in the first trimester at around 6 to 8 weeks of gestation. Usually, we have urogenital ridge from which the gonads develop. So, in a male, there is XY karyotype. In the Y chromosome, we have SRY gene, that is sex determining region of Y. This SRY gene is the gene which regulates the gonadal development. If the SRY gene is present and normal, the testis will differentiate the primitive gonad will differentiate into testis. And this testis, once developed, will have Sertoli cells and leading cells. This Sertoli cells will produce anti-Mullerian hormone, that is AMH. And this anti-Mullerian hormone is responsible for the regression of the Mullerian structure, which develops later from the urogenital ridge. So if there is no Y chromosome, that is, the karyotype is XX, there won't be an SRY gene. So these gonads will develop into ovary. Also, if there is no differentiation of testis, there won't be anti-Mullerian hormone. So there won't be development. There won't be regression of the Mullerian structures. These Mullerian structures will develop into uterus, fallopian tubes, and upper 2/3 of the vagina. Also, from the testis, leading cells will produce testosterone, which will cause the development of the Wolffian structures. Also, this testosterone, with the help of 5-alpha reductase enzyme, will become dihydrotestosterone, and this will also cause further development of the internal genital.
Okay, good. Mohandas, 2 questions. Whether we should repeat the karyotyping with 50 cells, that because sometimes that mosaics will appear in that, and the genetic study, an exome sequencing genetic study is a must in this case. These are 2 questions. Sir, Nishara Paraya and Mohandas sir will add.
One thing we have to rule out here is whether there is a possibility of mosaicism. We don't know whether we have to repeat a karyotype.
Since we don't have a very clearly specified karyotype report because how many cells they have counted and what percentage of cells they got XY and whether any other mosaic pattern is there. And our clinical picture can be explained with a mosaic turner also. I think repeating the karyotype is indicated.
What about genetic test? Sequencing or molecular genetics, as I was.
I don't think that is needed here. If, the thing is, if you want, instead of doing karyotype, you can also perform fish test where you can have specific probes for Y chromosome so that you can get any idea, any Y material is there. That is another option.
Yes, yes. Rajesh?
Yes, sir. One thing I want a question to Anuswara. Why gonadectomy was done for this child?
Okay, that is the question. Actually, that is one question in the chat box also. Okay, I just saw the chat box.
Okay, sir.
I can that is an interesting question. The sex of rearing, isn't it? So what is your what is your that is Rajesh's question is now the next important thing is the sex of rearing. How to rear this child as a girl or as a boy? And that is a very tough question nowadays because of the government rules are there. Anyway, this child is 10 years. Up to 8 years, it is very difficult nowadays. So what will you do with this child? Which is better? And then the question is whether that testis, so-called testis, should be kept in situ or should be removed.
Removed.
That is the Rajesh question. So can you answer? That is very important actually. Rather than the molecular, this is very important for the whole family.
Here,
a very tough question.
Here, one thing is the child has been reared as a girl child till 10 years of age. Also, according to external genitalia, there is only mild clitoromegaly. So here the comfortable option would be rearing as a female child. And about the gonads, there is also like being there being ambiguity in genitalia. There is one risk is if there is intra-abdominal testis, there is risk for malignancy also. So it is better to do gonadectomy in this child.
So what will happen if that testis is that so-called testis is there in abdomen for a long time?
There are chances for testicular malignancies.
So usually intra-abdominal testis, they are having much more potential to get a malignancy, gonadoblastoma, compared to the testis outside. That is why whenever there is a testis inside the abdomen or in the inguinal region, the surgeons will try to keep it outside actually, because chance is very less. And we can follow up that child with serial ultrasound of that testis and to see whether they will go for malignancy and not. But if it is here, it is not possible to keep it out. And so there is a high risk of malignancy also is there. So one option is, as Anuswara and Dr. Rajesh is telling, since the child is being reared as a girl child and with a normal external genitalia, only the problem is mild clitoromegaly that has regressed now. And uterus is there also. So it is better to rear it as female. Then I think that gonads has to be, the testis has to be removed because there is a chance of gonadoblastoma in that child. Another possibility is there one question in the chat box. Why can't the child be reared as a male child and make the gonad? And then what will you do with the gonads? He has not mentioned. Why can't you rear the child as male? What is your answer, Anuswara?
Yeah, we are planning to keep the gonad there is no there is no radius scrotal fusion to keep the testis outside also. Also here the genitalia correction, it would be more feasible to rear the child as a female.
So that question is it better to rear this child as a boy by preserving the testis and removing the uterus? That's the question. So your answer is that it is very easier because my answer is the child is being reared as a female and we have discussed with the parents and actually with the pediatric surgeons, we have discussed which is better. And since the child is having a normal external genitalia, and which is very easy to convert to you, because there is no need for any severe surgical procedures. But if the child has to make that a male external genitalia, that is very difficult. And keep the testis in the abdomen is very dangerous.
Yes.
If you keep that, if it is possible to keep the testis in the inguinal or in the scrotal region, you can monitor at least. But you keep the abdomen, keep the testis in situ in the abdomen is more dangerous also. So in that way, I think my opinion also is to keep the and remove the testis and rear the child as a female. And one more comment is that gonadectomy is done as they are having higher chance of developing tumor. Very good. Any other opinion from anybody? Opinion of
now the child is having a Y chromosome.
yes.
Yes.
Child have a uterus.
Yes.
Child don't have a ovary. Child don't have testes.
Yeah.
So apart from this Y chromosome, everything is like a turnip.
Yes.
Yes, sir.
Yes.
So when this girl grows up, whether this Y chromosome can have some effect and she will have some gender identity issues like that. So make it reports.
That is a tough question actually.
Hmm.
So that gender dysphoria will be there. We have to look for that. That is not as simple.
Sir, one more point I would like
But
to add.
actually, one thing is, but the imprinting, the intrauterine imprinting might not have been done because external genitalia is just like a girl. Hope that testosterone production is not much in the intrauterine period. Oh,
Sir, we couldn't do AMH level because the child came after gonadectomy. After surgery only they came to IMCH. So we couldn't do AMH level.
so if the child is there in the infertile period with us, I think we could have done AMH level also.
Vijayamaru, what about the further plans by the time she goes into adolescence? We are going to induce this thing with cyclical hormone therapy, and in that situation, suppose she get married at after 20s, they want a baby. Isn't that possible with other techniques? The uterus and the changes in the uterus favorable for the conception is possible with the hormone, and you can go for the artificial methods for having a baby. Still possible, okay?
Yes, sir. That is what we are. Next question is that now what we will do with this child, what we have started doing, and what is the future plans. Now the child is being reared as we decided to rear this child as female, and gonads are gone now. Sir, what to do? And Anashwara, what can be done? Sir, the exact questions sir has asked.
Now the child is 11-year-old. So now we have started her on low dose estrogens. And our plan is to maintain low dose estrogen for a period of time for the breast development and for the height gain. And later we can plan on cyclical hormone therapy. We are
actually, yes, actually, when to start estrogen, if it is a girl, to be reared as a girl, that usually happens in Turner syndrome and all. If you start a little bit higher dose of estrogen, that will produce the closure of the epiphysis and the growth will stop. So that is one problem of very early introduction of high dose of estrogen. But we have to start estrogen at the time when the puberty starts, because estrogen has lot of actions apart from the uterus development and all. Even the bone mineral accrual is based on the gonadotropins level. So if you delay estrogen, then bone mineral accrual won't occur properly, and the child will be having a risk of osteoporosis in the later life and all. So what usually we are doing is, during around the same age, like 11 to 12 years, we can start with a very low dose of estrogen for a longer time, and then gradually elevate the amount of estrogen. And once the destroyed bleeding occurs, we can add progesterone, just like cyclical bleeding, and we can continue that. That is the usual thing. So we just started on a very low dose of estrogen very recently. Along with that, we have started calcium and vitamin D supplementation, because bone mineral density, that problem is a usual problem. And we are planning to continue this and see whether child develops breast development and normal pubertal cyclical bleeding and all these things. And another thing is whether the child will be fertile or not. That is another question. And here one thing is that that uterus is there. So as Sir was discussing, in the coming future, we have to discuss about a lot of things regarding the fertility, what options we can do. All these things are still, some questions are there.
The donor ovum, we can carry a fetus in the
Oh,
the donor ovum.
donor ovum, all these things are there in the pipeline. A lot of things we can do.
One point and the follow-up of this child, from here itself, I think there are two investigations which are a must here. Because there is always, as one does point out, there is a possibility of it being a Turner. And in the context of the horseshoe kidney, very high chance of the obstructions of the ureters. We at present it may not be significant, but we need to have an anatomical knowledge of the pelvis and ureters. And the second thing is, always we may be missing an aortic abnormality. So a CT angiogram
Yes, sir.
or baseline data
Yes,
is
sir.
needed. On the follow-up,
Yes,
they
sir.
may develop these problems. Two investigations have to be done before we follow up.
Actually, what again Sir said the very valid point, because whenever we diagnose a Turner during our and we won't look only for his endocrine problems. Immediately, if you diagnose a Turner syndrome or endocrinology clinic for somewhere, we will look for visual problems, hearing problems, heart disease, or renal disease. All these things we have to investigate. I think we have to investigate this child also in that way. We have to assess the hearing, assess the vision, assess the heart, kidneys, all these things we have to do. I think we have to follow up just like follow Turner syndrome. Alle Mohandas, sir.
Yes.
Any other questions,
Sir.
sir? Rajesh?
Sir, രണ്ട് മൂന്ന് points. ഒന്ന് clitoromegaly, what is the size when we can say that clitoromegaly, micropenis?
Clitoromegaly, usually normal clitoral length is 0.9 millimeter and width is 0.6 mm. Any values higher than length more than 1 centimeter and width more than 0.6 mm is considered as clitoromegaly. And about micropenis, we have to look at with the stretched penile length. The length should be taken from the pubic ramus to the tip of the meatus. So at birth, normal infants, normal term baby will have a stretched penile length of 2.5 centimeter. Any value less than 2 centimeter or less than 2.5 standard deviations can be taken as micropenis.
Okay. In which all situation you will consider the DSD?
DSD,
like
in
like
any in case of a male, any bilateral cryptorchidism, all cases of bilateral cryptorchidism, all cases of unilateral cryptorchidism with hypospadias, any case of severe hypospadias, that is venoscrotal, scrotal or perineal hypospadias, and in case of a girl child or female appearing genitalia, any case of asymmetry in the labia or asymmetry in the genitalia, any palpable inguinal swellings or palpable gonads, and any degree of labioscrotal fusion should be considered as. Or in other cases, if there is discordance with the karyotype and genital phenotype, we have to consider it as DST.
Sir, hypospadias, sir,
investigate
hypospadia normally glandular. Sir,
suppose the child is having a glandular and shaft hypospadias in the shaft. with normal testis and all, that may not be a DSD. Suppose if the hypospadias is either scrotal or penoscrotal, severe hypospadias, that may be a DSD. Or if any hypospadias, if it is associated with either absence of one testis or two testis, you have to investigate. Otherwise, the simple glandular hypospadiasis with both testis palpable, that may be a male. Okay. And one thing, as Mohandas was telling, the psychological aspects of the children with DHC is very tough. Actually, when we rear a CAH in our pediatrics age group, we won't feel that problem. But whenever all these children goes for adolescent, even a case of simple CAH, simple X DST CAH with some virilization, will have some amount of psychological problem during adolescence. We are seeing many adolescents, many require psychological evaluation. We have to send to psychiatrists and all these things, because that imprinting of that hormones will be there. Everybody is having some or other forms of gender identity problems. Then regarding AMH, Rajesh was telling something about AMH. Can you tell what is its use of AMH in infancy?
Like AMH, presence of AMH usually indicates there is testicular function. So the measurement of values of AMH can be useful in detecting testicular function in children.
Yeah. Suppose if you do testosterone instead of AMH, like, what is the fallacy of doing testosterone? That is also a testicular function.
Testosterone, for testosterone levels is usually controlled by the gonadotropin levels. So, like if the child is not in puberty, so the testosterone levels may not be high. So, measuring after 6 months, the testosterone levels will not show the testicular function.
So that is why during mini puberty, just after infancy, after 2 weeks till 6 months in a male child, then there will be some high testosterone you will get. After that, testosterone level will be very low until the onset of puberty. So in between these childhood days, if you just do testosterone, that doesn't have any value at all. So we have seen so many prescriptions doing testosterone, dihydrotestosterone in a 4-year-old, 5-year-old child. That doesn't have any value unless you have to do stimulator, HCG stimulation, that it doesn't have value. But AMH, it will tell you something about the gonadal tissue. That is the importance of AMH. And during puberty, that will come down. So what is your conclusion now? Any more discussion? Mohandas, how time?
8:55.
9 o'clock.
9 o'clock. In 5 more minutes.
Hello, sir.
Any comment from Hiba? Hiba
Hello.
is what? Hiba?
Sir.
So any comment?
That was a very interesting case, sir. She discussed it very well. Initially, we thought of like a 46XX DSD because that was a girl presenting with a clitoromegaly. But at the end, it came up as a 46XY DSD. So it was a little bit complicated, but she presented it very nicely, and the discussion was very informative. So can I ask some questions, sir?
Yes, definitely.
Because this child is a very intelligent girl. She herself noticed the clitoromegaly.
Yes.
And she's already 11 years and entered in puberty. Her gonadotropins are also very high. So is she aware of her condition?
She is aware of her condition. I think we have discussed. I think now we have to discuss always.
Yes.
We have to discuss
that is,
in the
I think that
of
is very important, because we are always discussing with the parents. So how we should rear the child. I think we should also discuss with the child about because there was some testosterone action was there, some clitoromegaly is there. So is there any gender dysphoria, or is there some confusion from the child?
So as far as
requiring some counseling?
That is very complicated issue, Shiba. Actually, this child just entered puberty. He knows something, but he doesn't know much. That is the situation. As far as our court decision by Kerala and Tamil Nadu, till 80 years, we cannot do even a surgery without the consent of a child. After 80 years, with the consent of the child only, we have to do the extensive genital surgery and all. That is why so many genital surgeries are getting delayed now because of the court order. And we have to form a medical board also. And we have to include the child also in that counseling. That because finally the child will suffer, not the parents. All the gender dysphoria, all these things will be there with the child. So here, now the child is, he actually, and she, as you said, he is very intelligent. And this is the first time, I don't know, Rajesh, whether we have heard a case of clitoromegaly that is pointed out by a child itself. That is very difficult. Actually, he knows, he is having some idea. And he only told that there is some prominence. That is very rare, actually. And now, and she is very intelligent. And we have discussed with the child. And everybody continues, everybody decided, including the child, decided that she should be reared as a female. And even the importance of gonadectomy also we have discussed, actually. So otherwise this can produce some malignancy and all. That is why it was removed. That is documented. But what will happen is there, because of some testosterone effect is there. I don't know how that testosterone may be there in the intrauterine period, because the mini puberty, all these things. So there will be in the first trimester itself, there will be some amount of testosterone production from the gonads will be there. Then during that, just after delivery, there will be again some surge of testosterone will be there. Then testosterone will be then the very lower level. And during puberty, this is happened, and there is some amount of clitoromegaly. But what is the effect of intrauterine testosterone on the brain development? All these things are very big problem.
Yes.
That is not very simple, actually, as we have to follow up with her mental condition also.
Thank you, sir.
Rajesh. Good question, Hiba.
You can wind up, sir. Isn't it?
She has presented excellently well. She should be congratulated. It's a very interesting case. And Dr. Rajesh also needs an applause for selecting such a case. And it was wonderfully discussed by Dr. Vijay Kumar. And one thing, I don't have much experience in DSD. So in the differential diagnosis, this particular entity has not come. The end of our history and clinical examination. I think this DD was not there. So whether that also need to be included in the differential diagnosis, or is it a very rare thing that an X-ray presenting as clitoromegaly?
It may be there, but I think if it is a gonadal, some tumors and or something like that, there will be very much prominence will be there. I don't know, many cases will be missing. And we have a Dr. Shankar is there, actually in the our.
But keeping
yes, Kumar, I am here. I am just hearing.
Yes,
excellent discussion.
Shankar, any idea? Any your comment?
No. I think it's good case. We have seen few cases like this. So I think definitely a female type of external genitalia with clitoromegaly. One DD is always a 46XY.
Yes.
So we are
actually purposefully we kept it like that. In the beginning, we will discuss.
I think it has done beautifully. Discussion has gone very beautifully. And only one thing what I felt is a mixed gonadal dysgenesis is usually very rarely can present like this. And mosaic pattern, usually we expect in the karyotype, but most of the time we may not get it because it will be a low-level mosaicism, which even if you have done 50 cells, even if you do 100 cells, 200 cells, sometimes you may not get it. There will be some mosaic will be there, but you are not able to detect it. Low-level mosaicism will be missed in most of the karyotype. So that may be the reason. There will be some mosaic pattern will be there.
Yeah. Thank you, Shankar, for joining with us.
I'm hearing it's an excellent case and good discussion.
Aslam is the zonal coordinator who coordinated all this. Aslam, are you here?
Aslam?
Aslam, no. Aslam?
Hello, sir.
Ah, you can wind up.
Okay, sir. First of all,
Some two device ഉണ്ടെന്ന് തോന്നുന്നു.
okay. It's not reading in the laptop. That's why I take the mobile. Okay.
No, it is echoing.
Hello.
Yes. Oh,
Hello, sir.
now okay.
ശരിയായി.
Hello, sir. Hello.
Hello,
Yes,
Aslam.
now it is
കേൾക്കാം.
It is
പറഞ്ഞോളൂ.
clear.
Okay. First of all, I thank State and District Office Bearers of IAP Kerala for planning and organizing this academic session and providing all the supports to conduct this program. And now I thank our faculty, Vijayama sir, for beautifully discussing. And this topic is a very difficult case actually. And sir discussed without any ambiguity. Sir discussed this case. And now I thank Rajesh sir for very well mentoring the presenter and contributing to this session. Also, thanks to Dr. Hanishira for your wonderful presentation. Now I want to thank and express my gratitude to senior faculties like Purushottam sir, Srinivasan sir, Shankar sir, and for enriching this program with your presence. Thank you, sir. Also, thanks to all the participants who made this program a grand success. And special thanks to Mohandas sir, Dr. Njit, Dr. Jishin and Sindhu madam for working behind the scene and for the success of this program. Once again, thanks to all. I think we can wind up the session.
Thank you so much.
Okay, sir.
Good night.
Thank you. Good night.
Thank you, sir.